So Andrew's duly given us a welcome and made the opening comments, and it falls to me to talk through the remainder of the agenda and bring people up to speed as we always do at this time of year. And I'm going to cover 4 key areas. That's the progress we've made in 2021 so far, the strategic plan for the next 5 years, the funding and subscriptions to support that plan, the funding and subscriptions changes needed imminently, and the finalisation and approval of the plan, how that process is going to work. Now, I would like to spend most of the time talking about the strategic plan, exactly the objectives behind it and how it's all going to play out. I've been around long enough to know that I suspect we'll spend most of the conversation on the financing and subscriptions, because we've all been at these meetings before, and that tends to be the topic that draws most attention, and that's fine. We welcome that discussion, but we'll talk through and see how that goes. To Andrew's point, if you have a point of clarification because there's just something on the slide or on a topic that you don't understand, please do raise a hand and we'll try and take that on the way through. If it's sort of general comments, points, questions, etc., about direction of travel or how things are going to work, etc., I'd be grateful if we can kind of work through first and then take those in a wider discussion at the end. And I do hope we'll have a decent discussion at the end. So this is, believe it or not, this is actually the 5th time that we've come to talk, or I've come to talk to you at these meetings about the strategy anyway. Now, PHIN in 2021, the big news is, I'm delighted to say that yesterday we launched the new version of our website. I hope some of you have had a chance to have a look at it. It's on the same address as the old one, obviously, so the old one is now gone. I'll talk a bit more about that in a minute, but we're really proud of it. It's the first one that we have produced that is the product of proper patient research, understanding how they want to use the website, understanding what they want and need from it, and really a whole set of improved processes, from the fact that we brought the entire design and development process in-house. It's the first generation of our website that hasn't been reliant on external agency support, so that massively increases control and reduces cost. And it's been, I think, a well-managed process throughout. We've significantly improved our project management capability over the past couple of years, and it's really shown in this project. So we're really pleased with it, and we hope that you'll like it. We hope the patients will like it as well. Just a couple of other things before I look at the changes on the website in a bit more detail. Other things we've done this year, we've improved the publication of our data sheets, so they're now broader and much more reliable. This is something which has come up in previous member meetings quite regularly, but that data is now out there and available for members and indeed others to download and conduct their own analysis on it if they wish to do so. So we're pleased to have done that. Publications in terms of measures for 2021, well, the patient satisfaction scores for consultants are already actually included in the new website. You'll have to look quite hard for them because we only actually have sufficient data to publish for, I think, about 800 consultants at the moment, which 2 or 3 years into the process is slightly disappointing, but that's where we're at. So we're managing to publish those consultation scores. They are there, they do work. Yes, patient satisfaction for consultants. And just to remind people, if you weren't involved, that the way that we've gone about patient satisfaction, particularly on the consultant side, but also on the hospital side, was very much the product of a sustained consultation across the industry about how the industry wanted to do it. It was very much the format that hospitals and consultant representatives together selected in terms of the approach and the questions. Then later in the year, we'll be publishing a couple more new metrics. Registry links are very, very simple, and they should work, I think, both at hospital and consultant level. And that's essentially where the existing national clinical audits and registries have individual pages for hospital or consultant profiles. We'll be putting links to those on all of the profiles for our consultants and hospitals, which is quite a basic first step You may or may not recall that the CMA's order says we should take information where appropriate from the national audits and registries. We've been years in the discussion of how we can exactly make that tally up and work properly, but we want to just take a forward move so we can at least direct patients to know that there is further information available. By far the more sort of complex and involved process will be around hospital reported adverse events. Now, adverse events initially, these are sort of not in the bucket category of adverse events so much as the ones spelt out in the CMA's order around mortalities, readmissions to hospital and unplanned transfers, although there is also in there, I think, serious harm events. And the hospital reported on the basis that these are the figures that that hospitals know about and that they would, for example, report to the CQC, or were they able to do so through NRLS, National Reporting Alerting System, because they're the ones you know about. And this in itself is an interim measure where in due course, what we've long been working towards is being able to link the data that is used, that flows between private hospitals and the NHS, to make sure that we're aware of readmissions, for example, into NHS hospitals subsequent to treatment in a private hospital. And in particular, we got great feedback from Nuffield Health and Spire Healthcare and the Horder Centre, Horder Healthcare, following their work with the Getting It Right First Time programme, where it was that kind of linked data and information about what happens to patients post-discharge, and that was found particularly useful in clinical management. So it's the hospital reported adverse events this year, and as I'll come back to later on, we'll progress in other directions later. Also progressing in the background is our PROMS review. Thank you to many organisations that have been involved in that. It's being led for us, you may be aware, by the London School of Economics, and we'll be coming back with the outputs from that later in the year in terms of what we've learned around the implementation of PROMS, what could go better, how we improve things going forward, and so on. So, just a brief look at the website and what we've tried to achieve. As I say, it's based on original patient research, and what they asked us for was a cleaner design that's less cluttered and easier to navigate. They wanted to improve elements of the way that we search the website and bring back results. So we've moved from the sort of list view that was there previously to these cards, and they work really nicely. They also create the opportunity to drop in contextual bits of information that we didn't have before. There's richer content on the website now to help people understand and explain and contextualize the information, better profiles for consultants. And the overall effect of this is to try to give patients a clearer call to action, to make the journey through the website clearer, so that people come on expecting to sort of investigate their options and should go away with the opportunity to understand which consultant or which hospital they might want to pick up the phone to or send an email to. So that's the journey that we're hoping people will go on. Please do have a look at the website. We're very much still open to feedback. These things are never completely done. Of course, it will continue to evolve. But yesterday was a real milestone, and we're pleased to have got there. So one other thing, just to give you a heads up on as a coming soon, we've talked to you in the past, and it was warmly received as an idea in the consultation that we did on our strategy last year, around giving better information back to members and stakeholders. In terms of what comes straight back to hospitals and consultants, we'll continue to work on that within our secure portal. But we're also going to try and take those data sheets, the data sheets which reflect the information we've already published on the website, and put a graphical front end on that, an interactive graphical front end that we're working on now, so that you don't necessarily have to download the raw data and put it through your own analysis. It will create the opportunity for people to have a look at private healthcare and understand the patterns of private healthcare and what goes on in a slightly different way. So that is also coming along. It's worth just mentioning where we're at with our public partnerships with the Acute Data Alignment Programme. This is now in pilot phase. It's highlighted here as pilot preparation, and we're calling it that because we haven't yet received the first data back from any of the pilot sites, but we think we're pretty much now good to go on that. It's been a long process of working out all of the data protection requirements, the legalities, the things that we needed to do to make sure there are appropriate arrangements between hospitals and NHS Digital, to have NHS Digital ready to receive the data, etc. But just to remind people, the pilots will test three things. They'll test what happens when we send data to NHS Digital and their ability to synthesize that with other data and then hand it back to us. They will test private hospitals submitting their private data alongside their NHS data by the same channels, and they will test NHS private patient units submitting private data alongside those same channels. Please, in the meantime, if you are a pilot site, keep sending us your data in the normal way anyway. These are being run alongside, but we're aiming to get to reviews and recommendations of that in early 2022, with operationalization as soon as possible thereafter, so that this data sharing initiative, which has had huge support from across the industry and from wider stakeholders, can really start to get going. And obvious audiences who are keen to receive that would include the Care Quality Commission, who at the moment have very lopsided data about private healthcare, having all the HES data for NHS, but not for the private care, and organisations like Getting It Right First Time and the National Consultant Information Programme, about which more later. So the other thing we're working on at the moment on your behalf is the Department of Health's responses to the Patterson Inquiry recommendations and the Medicines and Medical Devices Safety Review recommendations. You'll be aware that that whole process went very, very quiet during COVID. The Minister, Nadine Dorries, then made a statement in March about some of the recommendations in the Patterson Inquiry, but not all, and critically not the ones about information in which we're most interested. However, as of May, I hope most people are aware, the work at the DHSC is now kicked off in earnest. They've got a new and reinforced team there. They've got some pretty clear deadlines. They want to make a further ministerial statement in more detail at the end of this year, which effectively means that they want to get all the solutions sorted by October. And so they've divided the solutions up by the different recommendations in the Patterson Inquiry and grouped them. We're part of the team working on Patterson recommendation 1 and 3, where 1 is the repository of information about consultants, who they are, what they do, bringing to bear data about the work they do and making sure that that is both available to the public and used across the NHS. And it should be immediately obvious why PHIN was considered very central to that, and indeed the ADAPT programme is considered very central to that. And also it's pretty clear why we are seeking to work with organisations like Getting It Right First Time and NSIP, who work across the NHS system, why they need to work with us indeed, because those organisations don't have the public facing aspect that PHIN has. Recommendation 3 again is about information, but this is the information that explains the differences between care in the NHS and care delivered in the private sector or independently. So it could be a more static form of information. We're actually trying to take it a bit further than that. And then we're also suggesting that the mechanisms we'll need to bring to bear to address those two recommendations from the Patterson Inquiry are very similar to those which would be needed to address the financial transparency issues raised by the Medicines and Medical Devices Safety Review, because ultimately it's about collecting information from consultants about the way they practice privileges, indemnity, financial interests, etc., being able to validate that information and then being able to get it to where it needs to be that patients or appraisers or responsible officers or whoever needs to hold that information. So we're trying to take those together. We're working with the National Clinical Improvement Programme, NHS Digital, the GMC, and indeed IHPN in a small group to get that done, hopefully over the course of the summer. I think I'll just take a brief pause there. If anybody has any immediate clarifications or questions just on those bits, ADAPT or Patterson and IM and DSR.
No hands up at the moment, Matt.
Good, I hope it allowed me to take a sip of water anyway.
Yes, okay.
I'm trying to talk fast so that I don't keep you all here all afternoon. But I'll move on. We can always come back to anything at the end anyway. Now, PHIN's strategic plan. We sent this out last week. I hope people have had a chance to look at it, or at least glance at it. It remains subject to approval, by which I will come back to this later, but to clarify, it has been approved by our board. But as we'll spell out in some detail, it needs approval both by PHIN's members, that's everybody on this call, and ultimately by the Competition and Markets Authority, who will see it as a joint plan being brought forward by PHIN and its members to set out how we're collectively going to get the order finished in a credible time frame. There's a reasonable amount of content in there, and we go into various different areas, but for the purposes of today, I'm going to just focus on the strategic priorities for the next 5 years, how that really focuses down around the order and the implications of that for resourcing and financing, because my sense is that's probably where members will want to spend most of the time. However, if you've got questions on the other areas or want to talk about any of the other areas in the plan, please do bring those back. So you will all remember, I'm sure, that we conducted a public consultation in the autumn of last year. We had a very good range of response from the people you'd expect to respond, IHPN on behalf of its members, other hospital members individually, a number of insurers, a number of consultant bodies, a number of patient representative bodies, organisations from the public sector, and so on. So we got a really good range of responses. And we put forward 4 strategic priorities, and broadly they were well supported. We've rearranged the order of 3 and 4 slightly based on the feedback that we got, but essentially just to remind people, they were firstly to complete and accelerate delivery of the CMA's order requirements. Secondly, to focus on the consumers so that we are ensuring that they will actually... Sorry, I heard somebody then.
No, it was an echo, I think.
Okay. Secondly, to focus on consumers to make sure that they can actually find and use and benefit from the information. Thirdly, was just in embedding ADAPT and the other commitments to partnership, particularly with the public sector, but not necessarily limited to the public sector, to make sure that we're pursuing longer term efficiency and effectiveness, not just within PHIN, but across the whole healthcare piece, with us acting on behalf of our members. And then to create value for stakeholders, where we explored some broader options on this, but we've really narrowed it down to that means giving people back good information in exchange for the data that they give us, really as much as anything else to optimise participation, equally to optimise understanding of private healthcare and shared understanding of what these things are. And just to sort of further clarify the feedback that we got, it was pretty clear steers from members and actually from all stakeholders. The overwhelming priority has to be delivery of the CMA's order. People want to see us get that done. There was some variance in the degree to which members wanted to focus wholly on that. I think the hospitals tended more towards focus almost completely on that. Other stakeholders certainly felt strongly that the information is only useful if meaningful if patients are actually finding it and using it, so that does still need to stay in the picture. But essentially that the priorities 2, 3 and 4 we should do, but to the extent that they support delivery of the CMA's order, and certainly not to the if they're going to distract from it. So we hear you, and we've adjusted accordingly. There was also recognition that more resources needed to get the job done in the time frame, and that would impact funding, and people asked for a plan. So funnily enough, that's what we spent the last 6 months putting greater detail into. Now, I hope you'll be glad to know that I'm not going to, however, dive into the full detail of our operating plan for the next 5 years, because I think that would drive everybody a little bit crazy. And we've also got a different mechanism for taking that forward. But there are some aspects I'd like to pick out and just remind people of a few things. So one of the questions that keeps coming back is, what does complete and accelerate mean? Firstly, complete, we set out in the consultation that had to aim for meaning all of the measures set out by the CMA for all of the procedures that are relevant for all of the consultants, for all of the hospitals, and available to use and understood by patients, because actually that's embedded in the order anyway. The assumption that the CMA is trying to achieve something and get patients using it is embedded in the order. Now, We can always have discussions around this, and I reminded myself of some of the feedback that we've got around all of the consultants and all the hospitals. Does that mean it only is valid if it has 100% participation at all times? I think we must strive towards that, but I think we must also push on and make progress even where we don't have 100% participation in terms of the breadth of information and how we use it, whilst always striving towards that full participation goal. And in terms of accelerate, in the consultation, we suggested that we'd aim to get the bulk of the order broken by 2023, and then move on to some slightly broader considerations to create value. Given where the appetite was from the consultation, and given what we then learned from looking at what that would imply for resource planning and scale up, being blunt, we've now decided that trying to do it over 5 years is probably ambitious enough, and that we would really struggle to do most of the order over 3 years anyway. We're going to stick to the priorities that we suggested. So, for example, we'll always publish hospital level information before we do consultants. It's a lot easier to do, frankly. It needs to mature as a hospital level. The measures need to mature as hospital level measures before we move on to consultant level. And we'll continue to be prioritised in our approach, so that we're looking for the doing the measures first, for the procedures first, for the hospitals and consultants first, that are going to have the biggest practical impact for people. It's not always necessarily the most numerous areas, but it will tend to be that. But we will always be mindful of what's actually going to create value. And how that shapes up, this is a slide that I showed you at the AGM, and again, I'm going to, there is a much more detailed plan behind this than now, as you might expect. But for now, let me just remind you, this reflects with the green that we're going to start by focusing on hospitals over the 5 years, and there'll be more emphasis on consultants, certainly in the last 2 years of the plan as we move forward. That we are going to do some of the simpler, more accessible, but relatively high value measures first. So patient satisfaction were done in 2021. The volume and length of stay has been improved. The in-hospital reported measures, as mentioned, and the audit registry links, those are all coming this year. And then we'll be moving on over the subsequent 2 years to looking at the more complex measures at hospital level, and maybe catching up with the consultants on some of the things we've already published up to that point, before we move on to complete the process in the latter 2 years. And you'll see here we've also put in, we're hoping that the ADAPT programme becomes operational in the latter part of this plan, and indeed that we're able to make genuine progress with the Getting It Right First Time and National Clinical Improvement programmes during this process, with the aim of overall system efficiency, and only doing things once when they could be done once, rather than doing them 3 or 4 times in parallel, as is usually the case at present. Now, I'm going to start talking about resourcing, and that's going to lead to financing. And here's a simple trade-off of which we've been very aware. When it comes to planning out resource, there's always 3 things that trade off against each other. There's your timescale, your scope, and the resource you're going to need to get a job done. And the reality of it is, what has happened in the first 5 years is that our resource has grown, but it's grown at a relatively slow rate. And slower than the rate that was needed to maintain timescales and scope. So 2 things have happened. The timelines have constantly got pushed out, which is why we now find ourselves 7 years into a 3-year implementation with a lot of work ahead of us. The scope was increased during the period anyway by the addition of the fees requirement in 2019, by the arrival of GDPR, making things slightly trickier, and so on. And therefore, we've also decreased the scope by operational necessity. So that's why we have to date published some selected and simplified procedures according to that strict prioritisation, rather than trying to do everything at once. And what I mean by simplified, for example, is at the moment with the hip and knee problems, we've published percentage improved, which is a decent measure. It is used by the NHS, but it's not the measure that is most relied on, which is the average adjusted health gain. So we've taken a simplified approach, and we've always strived for minimum viable products. We've just improved on that, I think, with the website. We're improving on that slightly with our portal. There are other areas where we've definitely stood in minimum or sub-minimum product territory, and that's particularly in terms of our own internal processes, I think. The implication of this plan and committing to it is this all reverses for the next 5 years. As we shift from the process of getting information in and focus on the industry more towards getting information out to patients and focus on the patients and the users of the information. But if we're making this commitment, that also means we're fixing the timeline and saying, no, collectively, we will get this done within 5 years. And we're fixing the scope because we're saying it's complete delivery as defined by the CMA's order with no excuses at the end of it. And therefore, the only thing that you can vary in this is resource. So we've assessed our resource requirements against that fixed scope and time. And if we changed away from that, that would mean making compromises. And it's not compromises in terms of things we'd like to do, it now be compromises in terms of the order. Because one of the things that PHIN has done over the last year is, we've heard the feedback. We understand that people want us really to focus on the order. There's no fat left in here. What we have done is really think about what is the resource requirement for getting this job done. And throughout this all, our watchword has been reasonable. And I'm going to labour this point a little bit because it has a very firm anchor in this whole process, which is that the hospital members are required by the CMA's order to bear the reasonable costs of PHIN as the information organisation doing its job, collecting this information, processing it, publishing it for patients. And the fact of reasonable cost just begs the question, well, okay, if you're going to talk about reasonable cost, what else do you need to define? Because reasonable, unsurprisingly, wasn't defined in the order. And to us, that means a reasonable timescale, reasonable scope, reasonable standards of delivery. So we're not doing this utterly half-heartedly, but we're not aiming for gold-plated either, but we're aiming to do this to a reasonable standard. We must maintain reasonable standards and processes for data quality so that it's fair to all participants and accurate. Reasonable standards of customer service, because thousands of consultants and hundreds of hospital organisations need to interact with us. Some patients choose to interact with us. And when people do, they should expect that we deal with their queries and concerns and so on reasonably well, and so on. Right through to reasonable expectations for resources to do the job, and reasonable efforts on our part, of course, to contain costs and maximise efficiency, which I think is, you know, you would expect us to do. So that's what we've been considering all the way through. And to be honest, I think we've done a decent job, as we always strive to, of trying to balance all of these requirements. And I won't labour the point too much here, but I would invite people to consider what the opposite of this would be. So, for example, we've said we're suggesting that it should be done over the next 5 years. The obvious question then is, well, would it be reasonable not to commit to fully implement the CMA's order, given where we're starting today, over the duration of the next 5-year plan? Or would it be reasonable to patients not to commit fully to delivering the order as the CMA set it out, and therefore giving them the information to which they have long since been entitled to receive as patients prior to seeking treatment? And I guess our conclusion was no, not really, and therefore, you know, on we go, and we must push forward and commit to doing these things. Now, back in December, when we also talked about this process, we signalled the outputs from the consultation, as I've just done. We signalled that more resource would be needed. We talked about the timeframes, which are aiming for a sign off of the plan and implementation, a sign off the plan at this meeting and implementation from next month. We also committed at that point, and then reiterated later with some of the members, that we would convene a group to look at aspects of this in greater detail, that we would get on with the aspects that were reasonably settled, but where there were still some issues, and they were going to be principally around, we thought, fees and charges, and partly around secondary issues such as what exactly are we going to do about hospital pricing to sit alongside consultant fee information. We'd need another group. And the suggestion that we came to through working with IHPN was to take a small and nimble group modelled on the successful project management office type model that was used during the early stage of the pandemic, involving senior people capable of doing some rapid decision making with their organisations. And we got 5 willing volunteers who've been working with us over the last few months to start examining this in detail. Now, clearly they represent their own organisations, but as in the pandemic, they're also working on behalf of all hospitals. And my strong guess is that the questions that they're asking us and the things that they're asking us for would be pretty common amongst everybody. And they've asked us effectively to present a business case, and I'll explain in a moment why I put that in inverted commas, but it's to bring forward a business case that sets out the rationale, the drivers, the need for each bit of resource and how that impacts costs, and what happens if you don't have it. We have to explore the assumptions that sit behind it in terms of who will do what, and so on. And that's actually leading us through to starting to develop an SLA for hospital involvement, so we can be much clearer on what PHIN's needs and expectations are of the data that comes from hospitals and the processes that hospitals and consultants engage in to make sure that everybody's playing their part in the order. We're looking at the phasing of how we scale up, how the cost comes in, how we tackle things, the resource plans, of course, and the costs implied by that. And what we're aiming to do is reach a shared understanding. We're trying to explore these things. If there's a better way of doing things, then we as PHIN are very open to finding a better way of doing things. If costs can be avoided by other means, such as resource or support in kind, great. That has to be real, but we're very happy to explore those kind of things. We certainly need to explain our thinking. We understand that. The reason, however, is that I put business case in inverted commas is because we as PHIN are slightly caught between two key stakeholders, which is the hospitals on the one side and the patients and the public and the CMA on the other in terms of our responsibilities. And ultimately there is an order which says we've got to do a bunch of things. So whilst it is a business case and we're happy to work in that way, where we are bringing forward the rationale behind the resources we're seeking, we're also aware that at a certain level it's not really optional either for us or the industry to say we're just not going to do it, or we don't want to do this bit or that bit, because we're all under a set of legal obligations that we're not yet aware of any way that we could choose not to meet, if you see what I mean. So I think we all need to sort of bear that in mind. Now, the partnership forum has been a very productive process. It's working well. We were hoping to have got through the conversations before this meeting to have reached some conclusions. That hasn't entirely been possible. So that's led to a few changes and movements. But let me just talk about some of the key issues that have come up. Firstly, it's costs must relate to the order. People don't want to see costs going in here that aren't strictly related to the order. Well, that's accepted, and at this point that's embedded in the plan. There's nothing that is in our plan that is other than delivering the order. Now, you can look at something like ADAPT, which has broad industry support, and say, is that strictly part of the order? Well, actually, to us, that's in large part a medium to long term route to more effectively and efficiently discharging the requirements of the order by leaning into shared resources across the industry and reducing duplication. So that is how we see it. That is one of the original drivers for that programme, and it has a high level of support anyway. So we believe we are now sort of fully focused on the order. The next thing was the immediacy of increases. Because, as I noted a minute ago, we were originally aiming, and had been for some time, or had originally aimed to start this all off July last year, but of course COVID intervened. So we've long been aiming to kick everything off from this summer in terms of implementing the strategic plan, having got it signed off. That would, of course, have implied quite a substantial level of cost rise immediately. And the partnership forum, I guess quite reasonably, have said, well, we weren't really ready for that. So what can we do about it? So as I'll explain in a moment, what we have done is we've listened to that. We've deferred the decision-making process, actually bringing you in a formal way the request for approval of the strategic plan to later in the year, and consequently will delay the bulk of the implementation of the strategic plan to the early part of next year. We can't delay everything in terms of costs, as I'll explain, but that's what we're doing. And then just to reiterate, a theme that's come around a few times in that group is please give us some tiered options, right? Give us a gold, silver, bronze level, show us where you could take out cost or make compromises. Now, I completely understand the thinking behind this, I really do, and it's an utterly reasonable request, but it is really difficult, and it's really difficult because that's just not where we've aimed. I just haven't aimed for a gold standard. We knew that we'd be in these conversations. We've been anticipating from them for a year. David Hare, acting on behalf of hospitals who pay for PHIN's costs, has been an ever present on our board, of course, constantly reminding us of the realities of these things. And so we've just stripped out everything optional and everything which we thought wouldn't have an immediate impact on our ability to do the job that we're committing to. Now, at base, what this means is we're aiming for a reasonable likelihood of being able to deliver this set of requirements to a reasonable standard over the time frame of 5 years, which we think is a reasonable period. And the reason I'm stressing reasonable likelihood here is simply if we start to take anything out, it falls below a reasonable likelihood, which becomes unlikely, and that now doesn't feel reasonable. So we're struggling a bit with the tiered options, and we haven't gone down that route yet for this reason. And I'm happy to talk about that later. Now, I'm just a final word on the partnership forum for the benefit of this meeting, which is this. We're going to have a discussion about all of these things clearly in the course of this meeting, and that is right and proper. Thereafter, we're going to continue the discussions with the partnership forum through to the end of the year. And I would really ask that people allow those to run and understand that that is happening on behalf of all members, because frankly, we just don't have the resources in-house to have these conversations about resources and demonstrating our plan or doing business cases and those kind of things in parallel 300 times over with 300 different operators. We just can't do it. That's the reason for focusing down on this representative group. And we hope that process will be able to run through to a successful conclusion over the next few months. So in terms of our resourcing and our overall approach, over the last 5 years, we developed the capability we need in most of the required areas. So I think our governance is really strong. We've got resources in and good processes and leadership in engagement and in our informatics and technology areas, and they support the processes of collecting the data, processing the data, and then publishing the data. However, what we lack is capacity. We do lack capability in a couple of key areas, which I'll talk about, but what we really lack is capacity. We can do this stuff, we just can't do it fast enough to accelerate and complete delivery of the CMA's order requirements over 5 years. So what we're mainly asking for is additional resource to increase the capacity and speed of delivery. Most of those additional resources will be relatively junior. We're effectively filling a pyramid from the bottom. We've got reasonable leadership in the team. We've got too many instances of a single point of failure or a single person who might be a manager level person managing themselves to do tasks because there's nobody working with them. So that's what we're talking about in terms of the overall resourcing approach. Resources will, of course, be added in phases based on priorities. With the best will in the world, an organisation can only scale up so quickly. And those resources will be added over 2 years. As I say, it was going to be August 2021. I've deliberately left that in there. It will now be from January 2022 that we're adding in any additional resource. The note on this, of course, is that you need to add them fairly quickly, because otherwise you end up in a more difficult place. You want people to have as close to 5 years worth of impact as they possibly can to get this job done, with ending up with a minimal resource, because the later you add people, the further behind you get. And in terms of the actual key areas that drive resource, there are 2 principal areas that we really need to strengthen, and then other areas just sort of will need to scale to some extent to support those. And those 2 areas are really informatics and then engagement and member services. In terms of informatics, that is our engine room that does all the processing and analysis of data to turn that data into information. So they're absolutely essential to the production of performance measures, to the data quality management process, to the production of analysis that enables us to support consultants and hospitals, and frankly to the production of analysis that would give us a sort of insights that all members, especially hospitals, have been clear that they would like to get some usable information, usable and useful information in exchange for their data. So that's what this team does, and we just need to do more of it. We need to be able to do it faster. We've got a small team at the moment where the exec director has to be very, very hands-on. It works fine at the scale it's at, but it needs to scale up, which means that this is one area we'll need actually a little bit more senior leadership. And we need to move to a situation where we're not just managing the delivery of these performance measures out the door entirely sequentially, because 5 years will not give us enough time to do that. We're going to have to be in a position where we can manage some of these things in parallel. There are also some capabilities there which, because we always prioritise trying to get measures out, we just haven't done properly over the last couple of years, which is looking at our own business intelligence platforms internally, particularly to focus around customer support, and giving any information back to people. We used to do more of that than we do now. We've become wholly focused on the measure development process, and we need to balance that up a bit. So that area needs resourcing. And then on engagement and member services, I know I've said this to you many times over, but if I take the example of consultant engagement and support, we've got fantastic people doing our consultant engagement and support in the form of Anne and Ellie, but it is Anne and Ellie trying to interact with 20,000 consultants, a couple of dozen different professional organisations, and with hospitals and their consultant engagement processes as well, handling communication on the wider level, handling individual queries, handling relationships, participating in product development, and it's just too stretched. Now, you might imagine that what we're doing is then moving to a full consultant engagement and support, or a full hospital engagement and support model with massively increased resources. The reality of it is we're kind of not. What we have proposed is going from a team of 2 to a team of 5 and 6, and that's the same on consultant and hospital engagement side. Now, the reality of that is it might mean that one person could be predominantly oriented towards professional bodies, one person could be predominantly oriented toward working with hospitals in terms of working with their consultants, and they'll all take a share at taking some consultant queries. But this area that I'm using as an example, in common with the others that I will describe, we're not even trying to put in enough resource at this point to totally do the job. We're putting in enough resource to try to coordinate our partners to do the job. We will need hospitals to do a lot of work on consultant engagement. We will need them to continue to and improve processes for correcting data queries and resolving concerns around data quality and those kind of issues. And again, at hospital engagement, maintaining data quality, building out participation, those are the areas that need more resource. We do that job reasonably well, but it needs more focus to maintain that quality of data, particularly as we go from the high level measures that we've published to date into consultant level risk adjusted measures that need a really high level of data quality to be maintained at all times. So again, this is an area where we need capacity predominantly. And the one other area that we've put in here, I mean, there's a couple that I picked out here, things like Scotland, Wales and Northern Ireland, that's in our mandate. And I have to say, I don't think we've done justice to Scotland, Wales and Northern Ireland. We've become very Anglo-centric, probably exacerbated in some ways by the partnerships we've been building with NHS Digital and others, which tend to pull us towards England, but we need to think about those kind of things. And we do need to make some steps toward patient engagement, actually listening to patients, figuring out what they want, marketing promotion to drive usage, and I'm going to explain what I mean by that, and then things like insurer engagement. Now, let's bear in mind, for example, that insurers have obligations under the order. They have obligations to tell their policyholders about PHIN and direct them to our website. They therefore have a pretty firm interest in ensuring that the information that we produce is of a high quality if they're going to promote it. And so we need to work productively with insurers to make sure that they are meeting those obligations and communicating it. Also make sure that the products that we're bringing forward, that the information that we're bringing forward is doing the job in the way that they would wish it to. But the third aspect there is insurers have very high touch with patients. They're a very good route and channel of communication to patients. So if that should be a really cost-effective way, given that it's in the order anyway, it's required that there is that link, that we tell PHIN about it. Let's optimize the effectiveness of that. Let's make sure we're doing it well. Let's make sure that the messaging is good around that. Similarly, all consultants are required to direct patients to PHIN in their fee letters, but we've never been able to give any attention to supporting that process really, and making sure that it was done well and was effective and properly managed. So when we're talking about marketing and promotion, we're talking about really light touch things. We're talking about exploring those kind of partnership options that are pretty low cost. And for the first 2 years, it will be exploring them, we'll be testing the waters, but exploring those areas which are pretty low cost to see what can be done in terms of using available channels to raise our contact with patients, make more people aware, you know, focus on usability and what patients are getting out of it. So that's the area. Now, that takes us from resourcing into financing. And there's no easy way to put these messages. And if I'm being completely honest, I feel like I spent most of the last 2 years trying to find a set of words that would magically deliver the underlying message, which is we've got a job to do. We've been all doing a pretty reasonable effort at it for the last 5 years, but I don't feel that we could say hand on heart that we've moved fast enough and far enough to discharge our collective legal obligations. We therefore need to move faster. Moving faster will require more resource, and that will require more funding. I mean, that is what it all boils down to. And there's no easy way to dress it up, I'm afraid. So here it is. So you will have seen this chart that was circulated in the message last week and the strategic plan that was attached to it. We essentially feel that we need to slightly more than double our income over the 5-year period, you know, over the first 3 years of that, to enable us to resource up. That means slightly more than doubling our head count, probably not necessarily head count, because there are other ways of working in some instances, but as I'm saying, filling the pyramid from the bottom, to give us the sufficient capacity to get this job done over 5 years. And this is based on what we know about the job, what it entails, what we've learned from the first 5 years, and the pace of progress that we've honestly been able to achieve over that period. Now, this is the plan we've drawn up. We are working through the greater level of detail with this, with the partnership forum. And I just want to put a little bit of context around this as well, because we'll translate this into sort of fee per record and so on in a moment, as I did in the message. But historically, right now, PHIN constitutes 0.08% of the total income for private hospitals, or seen another way, of the typical fee that a private patient pays. You know, there are 800,000 patients a year, roughly £4 billion of income into the private hospital sector. We've therefore got, you know, £5,000 per patient average fee. And at the moment, we're charging £4 per record, 0.08%. This increase we're proposing will take us to 0.2%. Now, I'm very aware that that takes us from something which is probably a pure rounding error on the P&L sheets seen by, you know, for most finance directors, to something which is starting to be visible, to be something which is starting to just be visible as something which impacts margin and impacts bottom line. And I get it, and I understand that that's serious. At the same time, it also translates into you know, a fee per record moving from £4 to, it will rise to 10 and then fall back a little over the period of the time to around 9. And I try to place that in context. Annabelle Bentley made a useful comment at the AGM in December around, look, there's no more money, it all comes from patients ultimately. We're very aware of that. We embedded it in our values from the start. And so I think we do have to ask, would consumers pay £10 for this information? And of course, we can have a debate about that. I mean, on the one hand, it's not that different to buying a copy of What Car magazine before you buy a car or some other high ticket purchase, or certainly less than subscribing to Which if you're thinking about buying white goods. And those organisations also have additional sources of income, chiefly through advertising as it goes. But In that scale, it seems still within a reasonable context. If we look at other benchmarks like the fees that are charged by the National Joint Registry, which many of you will know are still around 12 or 13 pounds 15 or 20 years after they started, having worked their way slowly down. We're not reaching those levels. If I look at other benchmarks, like the amount of money spent by NHS England on running NHS Digital, which stands at 0.3%, would still be well below that, for example. So you can't be definitive about these things, but please know that we are aware of them. We give consideration to this. We are trying to make sure that we are acting reasonably and specifically not asking for anything unreasonable or that is disproportionate to the job that we're trying to do. As mentioned earlier, one of the key things that the Partnership Forum has brought up is that the immediacy of the requirement is difficult. So we've further delayed to January 2022 to allow dialogue, and in doing so, we've taken all available steps to curb the increases that will be needed from the 1st of August. However, about £1 million of unavoidable cost remains. And let me explain that. In 2019, we came to this meeting, July of 2019, and we said we're not going to raise fees this year, and we're not going to raise fees because our strategy is imminent, and when our strategic plan lands, we're going to be talking to you about much more substantial increases. So for now, we're going to hold it. That conversation will follow. In 2020, we came and said, okay, we hear you. We held our fees last year, but we're in the middle of COVID. Nobody wants to see fees increase or even engage in the strategic plan at the moment. So we'll hold it off again. We held it off another year. So we've held fee increases and we've held off these conversations now for 2 years. We have tried to make progress in the background. We can now hold this off another 6 months. However, some of that's caught up with us because at this point in time, PHIN is running at a loss. We've been eating into reserves and we've done that knowingly. Sharp-eared of you might remember that we said both 2 years ago and this year we'd run at a loss. Last year we managed not to. This year we've managed to reduce that loss below that which we budgeted for, but it's still going to be a loss. So some things we have to do fairly immediately. And that is why, per the note we sent to you last week, our income will need to rise from the 1st of August, in the year from the 1st of August, to on an annualised basis from 3.4 to 4.5, 1.1 million spread across the industry. Of course, during this extended negotiation period, it's slightly under half that. It's about £500,000 that will actually apply between now and getting the strategic plan signed off. That is an average of a 30% increase from last year, which varies by provider. If you think about what happened to all of our fee calculations, you will probably be aware, are based on the previous year's completed activity. So it's private activity in 2020. Now, clearly people fared differently during 2020. PPUs did very little business. Their fees might rise less than 30%. In fact, we're aware that some are going down, frankly. Other people will see theirs go up. We would hope that that would reach an equilibrium anyway the year after, as COVID starts to recede, we hope, into the rearview mirror a little bit. The effect, however, of that reduced 2020 baseline also means that the apparent increase in fee per record from £4.14 to £8.23 looks huge, but that is simply because if the baseline is suppressed by 32%, if you just stand still, then the apparent increase is nearly 50% before any other changes are made. So the fee per record indicator is not actually that helpful this in this financial year. So what that does is it pushes back the substantive increase that is in the strategic plan, which would be 6.6 million for the first year. The remainder of that would come from January, in the as the situation is currently framed, as we currently are, to try to get the strategic plan agreed, to go into further detail as required to make sure that people understand it, to resolve queries and issues, to explore other routes where we can, so that when we come back to you in December, we have a plan on which we're all agreed, and with which we can move forward. Now, there are various things that we've done in that to keep to defer that cost. Very briefly, that includes the board has reserved relaxed the reserves requirement from the policy of 6 months temporarily to 5 months, so we don't have to fully recover the reserves. We're actually running at about 4.5 at the moment, so that needs a bit of further discussion. That we've currently suspended all non-committed recruitment and suspended all other additional costs and spend that aren't already ongoing, so that we're not increasing cost in this period where we're continuing to discuss the strategic plan. That all feels like the reasonable thing to do. And our sincere hope and intent now is that we want to, and frankly, we need to get this now signed off and finalised by the end of this year. So when we talked about this in December, these were the timelines we set out. We were actually aiming to start some of the implementation on the 1st of January anyway, as discussed at the time, because we thought there are some items which are settled and we can just get on with them, where there is non-contentious, where the consultation fully agreed. And so we've made some small steps forward in some of those areas to date this year, but not going to make any more steps forward in this next 5-month period, but we made some small steps forward in the beginning of the year. We said we'd finalise the plan by the 31st of July. That's, by this meeting. We were still waiting for the DHSC responses on Patterson, etc. We discussed the budget and so on in further detail, and then we'd be getting on with it, and we'd be having those conversations over Q1 and Q2. So whilst things are delayed, I think we've met our, we've done what we said we would in terms of continuing the dialogue and continuing to engage on this, and we've just pushed things out. So the plan now is, the process now is this. The strategic plan that we circulated was approved by PHIN's board in May 2021. We need to come back to you as members at the AGM in December to seek approval of the plan. Now, that will be taken as a vote at the AGM. We then send the plan to the CMA for approval. Now, of course, we keep them informed all the way through. They've seen the same draft plan that you have. They are informed all the way through, but they will receive the plan. From the CMA's perspective, as I understand it, they are receiving a plan from PHIN and its members collectively. And of course, PHIN is literally a company of its members anyway. So I can't emphasise enough that when we get to that point, this must be PHIN and its members collectively bringing forward a plan that is a credible plan that will show the CMA and indeed the public how we aim to get the remainder of the order done over this reasonable time frame. So whilst we can debate the ins and outs of it and look in detail at how we're going to go about that, I don't think there is any debate around the fact that the CMA will be expecting PHIN and its members, the industry, to come forward with a credible and robust plan for how we see out the remainder of the CMA's order. That's how I understand it. Maybe our colleagues from the CMA might want to comment on that later. So what we're aiming then for is publication in January 2022. Of course, it's then subject to a public audience. They don't tend to pay a lot of attention to these kind of things. Some journalists do, not many. But that would then go to a public audience in January 2022, and would be aiming to get on with the substance of the strategic plan at that point, with optimism that we can do this, that we can get through the next 5 years, that we can run a good process, that we can get this information into the hands of patients that they need and deserve, that we can take that information that we're producing anyway under mandate from the CMA and turn it into something of real benefit in the context of Patterson and medical devices and broader partnership with the NHS. That we can start to see it bear fruit within the industry in terms of having a single, independent, credible source of information on which people can rely for making critical decisions, for basing elements of performance improvement, elements of governance, and so on. And that we can strive to make this not only the fulfillment of these obligations, but also just a positive thing of which we, the whole industry, can be proud and know that we've done the job that we set out to do, rather than being in the constant dialogue of that, for which I apologise today, that is largely around some of the more challenging aspects of getting that job done.